Now you can start recording.
Yeah. So good morning, everybody. It's that first Sunday of the month when the IHRS DNB Arrhythmia teaching program goes online. This is a 2-year-old decision initiated in the previous executive committee led by Dr. Yash Lokhandwala. And while we completed 2 successful years, the constitution and change of the IHRSCC did not change our basic idea that we should take simple things from electrophysiology, arrhythmias, heart failure to the cardiology PGs all over India. We know that there is a certain disparity in the availability of staff electrophysiologists. And I think this initiative may not completely fill that void, but it certainly gives an opportunity to the cardiology PG on a Sunday morning when probably some of them who still must take their routine rounds have finished their job and probably can sit by the computer for not more than 90 minutes. So that was other thing that we make it useful, we keep it time bound, and we involve the master teachers in the program. And with that philosophy, this time we have invited Dr. Yash Lokhandwala's team at the Lokmanya Tilak Municipal General Hospital, also known as Sion Hospital from Mumbai, to present this edition. So they have devised this edition about LPBB, and I'm going to leave it to Dr. Lokhandwala to explain how he perceives this particular segment and in general how he perceives the way we should go ahead with this program. Dr. Lokhandwala, floor is yours.
Thank you, Ashish. Good morning, everyone. I am hoping that today not only cardiology but also the third-year medicine residents can join in. I'm especially happy that the faculty for the cases is Mohan Nair, who is a very, very experienced and an excellent teacher and really knows how to bring things down to the basics. And for the left bundle discussion, we could probably have no one better in the world than Shanmukha Sundaram, who is deep understanding now of its anatomical aspects and applied anatomy. We selected this topic because it's become increasingly important in the last few years from a point of view of pacing, putting pacemakers, but also the left bundle branch block is very important in heart failure and in syncope, and often misunderstood or not properly understood, I should say. And therefore, we thought it's a huge topic. I think there can be an entire conference of a couple of days on the left bundle branch. But so this is not meant to be an extensive discussion. This is just meant to, whet your appetite, give some basics. And every talk, I think, that's what I've been told our people who are going to present today. Let the students go with at least 3 points from every talk. So keep it. So therefore, while it might be quite simple for some of those who are EP fellows, and also for some of those who are for several months into an institute which does a lot of EP, for them it might be quite simple. But sometimes it's for them also. I feel it's always good to go back, refresh the basics, be clear in the concepts, and for the rest, I'm sure it will be a lot of this will be very useful. So with that, I invite Mohan to chair the first talk and ask Sriram to set the ball rolling.
Thanks, Yash. It's always a pleasure to be on a platform with you, especially since we have those young minds in the program. And I think it's very topical to start with the anatomy and then go on to some case-based discussion. And the DNB cardiology students would greatly benefit from these studies because, formal teaching is not a part of DNB. So they get to see cases and discuss within their departments, but there's always this added knowledge you always get by collective discussion. I remember we used to have, even when, there was some time when my DNB students and Professor Call's DNB students would meet up together and then and then our results certainly improved. And more than the results, I think the knowledge they carry forward is greatly more when they are into a collective discussion group. And also for the young presenters, it's a great platform to start knowing how to present. And you saw them, some of them actually take a little bit of time getting into their sharing their screen, and which is going to be the new world now. But like you said, you've given them a very good brief, and let's see how they present. Whatever they do would be very much appreciated and acknowledged. And if there is some points, of course, there is Shanmuga, who is the champion of left bundle, and others, and you, Ashish, etc., and the other Rakesh, Professor Rakesh, and others who can join in and put in a few bits. But like Ashish said, stick to the basics and not get in too much of. The idea is to get the DNB involved, not scared by what they don't know.
Thanks, Dr. Nair, for those precious words. And I think let's start with Sriram, and I think Shanmuga will add at the end in discussion as to what more he thinks about the anatomy and structure. So Sriram, you can start.
Yes, sir. Is my screen visible, sir?
Yes, very much. You can go full screen and you're on.
Yes, sir.
Perfect.
Yes. A very good morning to one and all, to all respected teachers, my colleagues, and my dear juniors and my friends. Today, I'm going to present a presentation to give an introduction into the left bundle branch. So let us start from the extreme basics, that is the anatomy and the structural intricacies of the left bundle branch. So let us look at a short history. The first structure to be discovered was the bundle of His, as his name suggests, Dr. William His Jr. He noted that there is a solitary strand of connection which is there between the atrial and the ventricular myocardia. And he thought that that was the only conduction which was present between the atrium and ventricle, but not about the atrial and ventricular extensions of the same. However, in the year 1906, Dr. Tawara and his colleagues painstakingly they did multiple dissections, and they have anatomically and histologically demonstrated that there are atrial and ventricular extensions to the conduction system of the heart, and that they transition at the fibrous tendon, where the atrial system, it penetrates the fibrous tendon and it continues distally as the ventricular part of the conduction system. So let us look at the bundle of His and the left bundle branch. The AV conduction axis, basically it starts from the compact AV node, which is located within the triangle of Koch, followed by the penetrating AV bundle, the bundle of His, followed by a small part, which is a branching AV bundle, and followed by the left and right bundle branches. The His bundle, as we see, is it's an extremely small, highly insulated structure, which is present within a fibrous capsule, which is present at the atrioventricular fibrous ring, where it has penetrated the fibrous tendon of the heart. And it is the solitary myocardial connection between the atrial and the ventricular tissue. And it's a highly compact, small bundle-like structure. Followed by that, distally, we have the left and right bundle branches. The left bundle branch is the predominantly left interventricular aspect of the continuation of the bundle of His, more on the anterior aspect of the interventricular circle. So now let us look at the left bundle branch. It has been demonstrated to be a predominantly subendocardial structure, and it is more subendocardial as compared to the right bundle branch, which has been found to be predominantly intramyocardial bundles. As we know, the moderator band, it contains the right bundle branch parts. The inferior border of the membranous interventricular septum is the point where the bundle of His, it bifurcates into the left and the right bundle branches, and it continues peripherally till it ramifies into the Purkinje fibers. Dr. Durer et al., they found that there are three main branches of the left bundle branch as compared to that controversy whether there are just two branches or there are three branches. The three demonstrated branches were a very thin anterior radiation or fascicle, a wide posterior fascicle, and a small mid-septal fascicle, which was either a direct branch from the common left fascicle or it was ramifications from both the anterior and the left and the posterior fascicles. Structurally, if we see there is high individual variability in the positioning of the left bundle branch, and as a result of which we need to know the intricacies of the left bundle branch when we go ahead with the left bundle pacing, which is a recent development. It is a fan-shaped structure, basically, which is extremely thin and it is narrow towards the base of the heart and it widens as it progresses towards the apex of the heart. So the clinical implication is that because of a wide area and being subendocardial with less insulation, it has a low threshold and can easily be a target for pacing. So the diagram on the left is the one which was originally made in Dr. Tawara's thesis. The extremely important part about the painstaking dissections that he had undergone is that he had done dissections of almost 15 puppies, 15 adult dogs, 15 young human babies, and 15 adults, and even pigeon hearts. And he had done 9-micron slices, and he had demonstrated histologically of the location and the ramifications of the left bundle branch. And he even demonstrated how 3D reconstruction of the same, where he has shown this diagram, where we can see that this is the posterior fascicle, this is the septal fascicle, and this is the anterior fascicle. The same thing as a gross anatomical structure, as you can see over here, AF is the anterior fascicle, SF is the septal fascicle, and PF is the posterior fascicle. Now, Dr. Kulbertus et al., they had studied 49 human hearts and they differentiated that there are three main types of the left bundle branch. So type 1 is basically where this is the anterior bundle branch, the fascicle is a separate one, whereas the posterior fascicle is also a separate one. The septal branch, the septal fascicle, it comes as either anterior or posterior being the dominant contributor for its formation. The type 2 is one where there is anterior and posterior fascicle, and the septal fascicle is formed as a common ramification of both, and it is present overall over the septum, where you cannot delineate exactly from where both have equal contribution. And type 3 is where the predominant for fibers for the septal fascicle arise from the posterior fascicle. So the structural differences between the right and left bundle branch is that the left bundle branch is extremely thin. It has very less connective tissue surrounding it, very less insulation, and hence there are high chances of its degeneration and being affected. As a result of which, and especially among that too, the left anterior fascicle being extremely thin is most susceptible. That is why we see left anterior fascicular block being an extremely common phenomenon as compared to the left posterior fascicular block. So left anterior fascicle is a subendocardial structure, and whereas the posterior fascicle is present deep within the interventricular septum in such a way that it has almost penetrated to the right side of the interventricular septum, that it is more closer to the right ventricle. And whereas the right bundle branch, on the other hand, it starts off extremely thick. It has a very transient tapering, and it is highly muscular. It is a high muscular bundle, and it has good insulation and good surrounding protection around the right bundle branch. So this is a gross anatomical specimen of the right side view as well as the left ventricular view of the interventricular septum. This part where there is an illumination which is labeled as the membranous septum, that is the exact part which marks the membranous interventricular septum. This is the ostium of the coronary sinus, and this part, as we know, forms the boundaries of the triangle of Koch, and this is the septal tricuspid leaflet. So now, when we look at it from the left side, this is the right and the left coronary sinuses, and between that, the intersinus triangle. This is where the lower tip of the membranous interventricular septum is where the left bundle branch bifurcates. And you can see this structure as the left bundle branch. The one which is labeled as 1 is anterior fascicle, 3 is posterior fascicle, and 2 is the septal fascicle. Now let us look at it from the histological perspective. this small structure, this bluish structure is what is the membranous interventricular septum. This is the tricuspid leaflet or the septal tricuspid leaflet. And as you can see, just above the septal crest of the interventricular septum, there is this structure, brownish structure, which is the exact His bundle, which has been demonstrated histologically. And you can see that it bifurcates into the left and the right bundle branches. The right bundle branch is predominantly intramuscular, whereas the left bundle branch, as you can see, is just beneath a thin layer of the endocardium and subendocardial in position. So the histology of the fascicular blocks, which we commonly see, is basically a fat or fibrous replacement around the conduction tissue. And as we have discussed about the thicknesses, anterior being the thinnest, the anterior fascicular block is the most common, whereas the posterior is the least common. And it can be predominantly due to degenerative processes, and it can affect either only a fascicle or it can affect the entire left bundle branch. And left bundle branch block, when it occurs, it has complete bifascicular involvement, or rather, as a new concept, trifascicular involvement. So, a study by one of our, which was done at the Maastricht University in Netherlands, and one of the co-authors being our very own Dr. Ashish Nabar sir, this has demonstrated the variable activation, the septal patterns of activation in left bundle branch in heart failure. So what was noticed that in general with heart failure, there was earlier activation of the right ventricular free wall, which was slightly earlier as compared to the surface QRS onset. And there was, but however, if the hearts were completely diseased and sick hearts, there was delayed total activation of the heart, including the RV. Now, they found that there were predominantly two types of endocardial activation. As you can see in this 3D electrophysiological mapping, one of the patterns is where this small part of the mid septum, it gets activated first, wherein this pattern was where there was slowed sluggish conduction in the left bundle branch, and then it progressed in the form of activation wavefronts towards the base as well as the apex of the heart, as you can see over here in this second figure. And finally, the left part of the interventricular septum gets activated. This was one of the patterns, whereas this is the other pattern where, without any involvement of the direct involvement of the conduction system, there was, as we normally know, the septum gets depolarized from the left to right. Here, it gets depolarized from the right to left, and there is no activation of the conduction system, as a result of which we can see it initiates in the high part of the septum where the right to left conduction is present, and then it just progresses downwards, as you can see. This is similar. And they also noticed that there was significantly reduced conduction velocities around the scars and also in the globally diseased hearts. So what are the various sequelae of differential activation? Why are we even trying to understand this? Is that the asynchronous ventricular contraction which occurs because of this is the main reason for impaired regional as well as global ventricular function, which is why people with left bundle branch have a earlier onset of heart failure as compared to the other patients. And there is differential activation of the left ventricular papillary muscles. As a result of it, there is dyssynchrony between the papillary muscles having inadequate mitral valve coaptation, as a result of which there can be variable severity of mitral regurgitation and further causing heart failure. And globally diseased hearts, where you can see is basically even the right side of the ventricle there is complete disease and reduced conduction velocities. So when we are using CRT or cardiac resynchronization therapy, there are very exact parts which have to be demonstrated electrophysiologically, where we need to place the RV lead so that there is adequate conduction and the purpose of CRT is achieved. Another study which was done by Dr. Rosen et al., it showed that there are different HV intervals in patients with left bundle branch. So there are three types of HV intervals. One is the normal HV interval, which is less than 50 milliseconds, an intermediate HV interval, which is between 50 to 60 milliseconds, and prolonged HV interval, which is more than 60 milliseconds. The difference which they noticed during this study was that patients with normal HV intervals had predominantly ischemic or atherosclerotic or arteriosclerotic involvement of the left bundle. As a result of which, in these patients, it was possible to have isolated left bundle branch block. Whereas patients with prolonged HV interval, they were more common in patients who had hypertension or they had associated bilateral bundle branch involvement, causing a severe global conduction system dysfunction. And this was a very dangerous sign, as it was a harbinger of future complete AV block. The other subtle signs which we can pick up on surface ECG are that prolonged PR interval, QRS in duration of more than 160 milliseconds, and these have been found to be markers of prolonged HV interval. But this study did not demonstrate any definitive role of the QRS axis in the same. So now we have gone through the entire structural and anatomical aspects of the left bundle branch. So what is the clinical implication of the same? The thing is, nowadays conduction system pacing is on the rise because it is a more physiological pacing. So first type is his bundle pacing, but his bundle pacing, the main issue is that the his bundle, as we discussed, is an extremely small and highly insulated structure, as a result of which it is not possible to easily capture it. And hence it has a very high unstable threshold and it's an extremely small area. As compared to the left bundle branch, which is a fan-shaped, widely distributed structure, it has many ramifications and even capture of the peripheral aspects. It can easily cause adequate synchronous pacing of the left ventricle, and as a result of which this is now more on the forefront. The frontal axis shifts due to fascicular blocks. They are the main cause for this. It is mainly due to dysynchrony in the left ventricular activation. As we see in left anterior fascicular block, we have left axis deviation. So this is because of this synchronous LV activation. And the other thing which we can grossly see when we get patients is that patients who have left bundle branch with extreme gross left axis deviation and wide QRSs of more than 160 milliseconds, it can signify there are significant underlying LV dysfunction. To end this discussion, we can see this gross. It is just a small input into the new part of conduction system pacing. There is an anatomical and fluoroscopic landmarks of the same. This is the right ventricle, slightly it is upturned, that the RVOT has gone above over here. So this is the triangle of Koch containing the compact AV node, followed by the penetrating AV bundle. And the part which has gone on the other side, this is the left bundle branch, and this is the right bundle branch. And this red dotted structure, what we see is basically the left bundle branch, which has been divided into the posterior, anterior, and the septal fascicles. Now the fluoroscopic counterpart of the same, we can see this catheter, which is a decapolar catheter, which has come from the superior vena cava. This is the RAO, or right anterior oblique view, where it has entered into the coronary sinus. And you can see this decapolar catheter. These three catheters which have come from the inferior vena cava, this is the quadripolar catheter, which is marked as RAA, which is present in the right atrial appendage. And this catheter, which has been marked as his, is at the exact small tiny portion, which is the his bundle. And now the third catheter is at the apex of the right ventricle. And this image, which is the C image, is basically an image which is depicting the simultaneous his bundle pacing location and left bundle branch location. We can see it is just around 15 mm distal to the his bundle, and we can see that it has distinctly crossed the interventricular septum, and it is more on the left ventricular aspect. As the left bundle branch is a subendocardial structure, we need to go more towards the endocardial aspect of the left ventricle. So this is just as a fluoroscopic landmark to be sure about your lead positions while doing left bundle as well as his bundle pacing. Thank you very much for this esteemed opportunity for presenting in front of all the great teachers. I would like to learn more from you. So thank you so much.
Shanmuga.
Yes. So
Please.
yeah, that was an excellent demonstration of anatomy of left bundle, especially in the era of conduction system pacing. I think we should know how this left bundle is arising out of the distal membranous septum and how it branches. Because not all the areas of left bundle can be easily captured. In some patients, we can easily capture the proximal bundle. In some patients, for example, with infiltrative cardiomyopathy, where you can have scar here and there, you may have to go either into the posterior fascicular area or in the anterior fascicular zone very rarely to capture the conduction system. So it's essential to know how it branches, what are the variations in the branching pattern. I think he has demonstrated it excellently. So I just want to add on a few points here. So one thing he was talking about the course of right bundle. So right bundle, he said it is more deeper and thick. So it is thick, but at least in the proximal part, just to begin with, just immediately after the bifurcation, the right bundle is more subendocardial because we have seen more often the sheath, this C315 sheath or whatever sheath we are using, it sometimes goes and hits there, and we can see iatrogenic right bundle block getting occurred in the patient, and the patient developing complete heart block in the presence of baseline LV. So at least in the proximal part, it is more of subendocardial in the RB side. So we have to be very careful in avoiding our sheath reaching that target zone. So we usually keep that 0-degree axis in continuation with the his catheter from the quadripolar catheter. So that helps in identifying the right bundle. It usually goes in that 0-degree plane. So you just try to avoid that zone to avoid injuring the right bundle. And the important thing which he stressed is this left anterior hemi blocks are more common as compared to left posterior hemi blocks. So there is an anatomical correlation for the higher incidence, because when you see this histology, the left bundle, in fact, the his bundle bifurcation itself is not a true bifurcation. People used to say it as a pseudo bifurcation because the his bundle continues and it continues down as a right bundle, and the left bundle fibers takes off from the main course of the his bundle. The first to leave off is the left posterior fascicular fibers, and the last to leave off is the left anterior. Sorry, first to leave off will be the anterior fascicular fibers, and the last to leave off will be the posterior. So it'd be like a pseudo bifurcation pattern. The right his bundle continues as right bundle, and you have fibers coming out. And the bifurcation point, exactly when you see the histology, it's actually a pseudo bifurcation point where the crust of calcium can extend and it affects the bifurcation pattern. So that is the reason why this is more common as compared to the other one, because the fibers are closely related to the right bundle branch. And another important thing which I would like to stress here is the HV interval, which he was talking about. And the HV interval and the relationship, like I rightly mentioned, whenever we see a prolonged HV, we think more in terms of conduction system disease rather than a myopathy. So if you see an HV of 60, 70 plus in a patient with a baseline LVB, we plan for a CRT, it's more of conduction system disease. And this conduction system pacing is going to help a lot rather than a conventional CRT or even a large CRT. But in patients with either normal HV or in fact very rarely with a very prolonged HV, like more than 90 milliseconds, 100 milliseconds, there is more of a mixed pattern. So there will be a disease in the conduction system as well as in the peripheral area. So for that, we need to know where exactly the level of block is. So many times it will be in the distal his bundle, which is demonstrated in almost 70 to 75% of the patient, and proximal left bundle in at least another 5-10% of the patient. But at least in 20% of the patient, we can have disease extending little more distally, where you will not have, you will be having a very prolonged HV, like more than 90-100 milliseconds, which cannot be corrected by left bundle pacing alone. So HV of between, what you observed is HV of between 60 to 90 milliseconds. It can be corrected by doing a left bundle pacing alone. If it is more than 100 or less than 60, we may end up inputting a left bundle optimized CRT rather than left bundle pacing alone. And the last thing which is interesting is the segmental diseases, which we often observe by pacing the fascicles within the left bundle. We know the left bundle has multiple fascicles. So even within the fascicles, a lot of segments will be there. Very rarely in patients with intra-ACM disease, there may be some segmental diseases within the bundle. So if your lead is going on into that diseased fascicle, you can have a little prolonged stim to onset of QRS, because that area is diseased. The impulse has to catch the surrounding fibers before activating the myocardium. So within the left bundle itself, within the fascicle itself, there may be some segmental disease because of a diffuse disease below the intra-ACM system, which actually carries some point when you are doing a bundle branch pacing. So otherwise, I think it's an excellent presentation, and Yashar is there, Mona is there, they can add on some more points.
So for the students who do not know, Dr. Shanmuga is actually a world authority on, and we are proud of him. with many excellent publications in all the leading journals, cardiology journals of the world, and EP journals. So please, whatever he says is filled with loads of knowledge and experience. I would like to add some simple things, and some things have come up in the chat. Snehal Kulkarni rightly points out that in children, Mohan, I don't know if you observe, but children with left bundle who develop iatrogenic left bundle branch block, and they do sometimes quite poorly. This is after a ventricular septal VSD surgery, for example, or even a device closure. And normal left ventricular function in children sometimes deteriorates after this. The second point was that as raised that a left posterior fascicular block is stouter, plus it has a dual blood supply. So a left posterior fascicle can have is difficult, is much less common than a left anterior fascicular block. But if you do see a left posterior fascicular block, it's more sinister than a left anterior fascicular block. These patients have higher chance of developing complete AV block in future. The third point is just to reiterate what Shanmuga said, many times with a catheter in there, you can easily produce a right bundle branch block. So some part of it is superficial. And therefore, when you're putting catheters in patients with left bundle branch block, you're putting a catheter in the right side, be very careful. And vice versa, if a patient has right bundle branch block, if you're putting, for example, a pigtail catheter in the left ventricle, be careful. So these are some of the traditional teachings of cardiology. I think
Yeah.
in the interest, more some closing
just a few
comments.
points. From the DNB point of view, I think excellent talk. I would divide it into two parts. The first part was with anatomy and the intricacies of the anatomy should be captured by all these DNB students, because this could well be a full question. As you know, in DM and DNB, there's always a question on embryology and anatomy. And one could be that, describe the embryology and anatomy of the conduction system. And I mean, this is passive learning where just being present in this, if you can reproduce some of it in the theory question paper, it will be more than enough for you to clear. On the practical front, you might be asked to comment on an ECG of left bundle and then asked, the implications. And there again, we've gone through the implications a little bit here, and I'm sure the other presenters will reinforce. So that much is reasonable for an ordinary DM and DNB student. And of course, you could have a short note, definitely. Definitely, I would expect that at least a short note or a short question would be asked on conduction system pacing in any of these. If I was to set a purpose, there would be one. But that's so much in vogue. And if you're just doing cardiology, you don't have to be cardiology and trying to be an electrophysiologist in the future. We would like to have many of you taking this up. But, even a general cardiologist must know some basics. So I think I'm sure all of us who have been, even Professor Yadav would agree. Not knowing anything, being zero on a question, what do you know about conduction system pacing? Should be able to say something. So I think that this presentation is good enough. This is what is the beauty of such webinars and meetings. You had a passive learning and taken off a good number of learning points for your practice and of course for your exam.
Okay, so
I think that this left bundle anatomy, conduction system pacing, there will be one question in DNB final examination. So it is 100% true that you are going to get one question on this today meeting.
Yeah, so Rakesh has very high-end depth on what the questions are. I think he is setting the question paper, so be alerted to all the DNBs. You can't get a better clue than it coming from Rakesh. Thank you, Rakesh.
Okay. So with that good beginning and pearls of wisdom from colleagues now, Abhinav is a faculty. He's trained in electrophysiology, and he's going to simplify this topic of left bundle branch morphology tachycardia. And Mohan, I guess, will be chairing this talk.
Good morning, everyone, respected panelists. Before I begin, I'd like to thank Navasir and Scientific Committee IHRS for providing me with this opportunity to present in this webinar. Also, thanks a lot to Lokhandwala sir for his excellent guidance and support during the presentation of preparation and presentation of this topic. So my topic is approach to LVVB tachycardia, and we'll go straight into it. So when you see a tachycardia which has a left bundle branch morphology, ask yourself 3 questions. Is it SVT with LBBB? Is it a pre-excited tachycardia? Is it ventricular tachycardia? Even in these 3, you will realize that when we are talking about SVT with LBBB, the impulse is traveling around the normal conduction system. And this results in a QRS morphology that looks like left bundle branch block. Whereas in pre-excited tachycardia and ventricular tachycardia, there is a direct myocardial activation, and this results in a QRS complex that isn't exactly like left bundle branch block, but looks like left bundle branch block. Since we have broadly divided the tachycardia into left bundle branch block and LBBB like, it is important to know what a typical left bundle branch block looks like. For a typical left bundle branch block, the EAC 2021 criteria divides the QRS duration to be at least 120 milliseconds. This is because when the left bundle is blocked, the activation is going to proceed from RV endocardium to the LV endocardium. The time taken for this conduction to happen from RV to LV endocardium is 40 milliseconds. Then it takes around 50 milliseconds to reach the LV free wall. And then it takes additional 50 milliseconds to activate the LV free wall. Considering this into account, the Strauss trick criteria proposes a minimum threshold of more than 140 milliseconds in men and 130 in women. Next, we come to the QRS morphology. So these are in 2, 4, and 5. So since the activation of the ventricle is proceeding from right to left, we will get a positive wave in the left-sided leads, that is 1 AVL, V5, and V6. A small R wave due to depolarization of RV part of the septum may be picked up by the anterior leads, which is V1 and V2, which are close to the RV surface, but these are not picked up in the remote leads, and this leads to loss of septal Q waves in the lateral leads. Since the activation of LV proceeds from the septum to the free wall, in the middle, the area of activation wavefront decreases, and this leads to a notch or slur in the QRS. Then the ST segment polarity is opposed to the predominant QRS polarity, and the QRS axis is variable, but this will either be normal or towards the left. Now, when you see a tachycardia, which has a left bundle branch aberrancy, these are the 3 main differentials to consider. When you see a ECG which is suggestive of typical LBBB aberrancy, this means that the left bundle is either blocked or the conduction is so delayed that the activation is taking place down the right bundle, which is activating the ventricle. The impulse to this right bundle can broadly come from 3 areas. So this can be above the ventricle or supraventricular. This may be atrioventricular, which comes from a pathway that directly inserts into the right bundle. These are less common and are known as Mahem tachycardia. And the rarest tachycardia, which has a typical LBBB aberrancy, comes from the ventricle. And this includes the impulse which travels up the left bundle, conducts down the right bundle, and gives rise to activation of ventricle, which is bundle branch reentry ventricular tachycardia. So this is an ECG showing tachycardia with typical left bundle branch block aberrancy. Note that in all the broad three differentials that we discussed, the activation of the ventricle is going through the right bundle, and so the morphology of the QRS is going to be similar in all the three broad differentials that we considered. Since the QRS morphology is similar, to differentiate these tachycardia, look at the P-wave morphology, compare the baseline ECG, and look at other tachycardia characteristics which may be present, which may give you a clue to the underlying etiology. So this is a tachycardia, typical LBBB morphology. If you look at the P waves, it is positive in 1 in the inferior leads, that is 2-3 AVF, positive in V4, V6, biphasic in V1. So this was a patient with baseline left bundle branch block, admitted with pneumonia and had sinus tachycardia. Another example, tachycardia with LBBB aberrancy, irregularly irregular QRS, and if you see the baseline ECG, there is a underlying atrial fibrillation. So this was AFib with LBBB aberrancy. The only ventricular tachycardia with a typical LBBB morphology is bundle branch reentry VT. If you look at the rhythm strip here, there is intermittent peaking of the T waves. These are P on T waves, and this is suggestive of AV dissociation, giving a diagnosis of ventricular tachycardia. So this was a bundle branch reentry VT. Sometimes the tachycardia transitions from a wide complex to a narrow complex, and here you get additional clues. For example, here you can see as the tachycardia transitions from LBBB morphology to a narrow complex, the tachycardia length shortens from 330 milliseconds to 280 milliseconds. This is given by Kummel's law, which shows that in presence of ipsilateral free wall pathway, development of ipsilateral bundle branch block. So left free wall pathway, left bundle branch block, there is lengthening of the tachycardia cycle length by 35 milliseconds or more. This is because of the extra time it takes to traverse the septum. So this was a left free wall pathway, which you can diagnose based on transition of the tachycardia cycle length. Another clue is to look at the baseline ECG or ECG after termination of tachycardia. This patient, regular LBBB tachycardia, termination with adenosine 6 mg IV bolus rapid. After termination, if you look at the ECG, there is short PR, R more than S in V1, positive delta in the chest leads, negative delta in the inferior leads, and this patient turned out to be a left posterior pathway. In presence of LBBB tachycardia, due to atriovascular fibers, there may be presence of RS complex in lead 3, and this might give you a clue to the underlying diagnosis. In patients with bundle branch reentry VT, sometimes the rhythm may be so rapid that VA dissociation will not be apparent, and here you can take clues from the baseline ECG, which may demonstrate presence of intraventricular conduction defect and PR prolongation. Okay. In patients with ECG that is inconsistent with aberrant conduction, VT is the most likely diagnosis. A supraventricular tachycardia with LBBB aberrancy and ventricular tachycardia, they demonstrate marked differences in the manner to which they engage the His-Purkinje network. For example, in a SVT with aberrancy, the impulse is still conducted down the right bundle during the initial part, and the initial part of the deflection is rapid. This results in a R wave duration that is less than 30 millisecond in V1 or V2, and a RS interval that is less than 100 millisecond for QRS complex. This contrasts to the myocardial VT, where the initial conduction is from muscle to muscle and therefore slow. This is the basis for diagnostic algorithms. For example, RV peak time more than 50 milliseconds in lead 2, RS interval more than 100 milliseconds, or slurred initial component of the QRS complex. When you see a ECG that is suggestive of ventricular tachycardia, it is important to treat the underlying disease and not just the rhythm disturbance. A ECG, which is ventricular tachycardia of LBBB-like morphology, this can again be divided into structurally normal heart, which may present with outflow tract VT, or underlying structural heart disease, which can again be divided into ischemic or non-ischemic causes, which may be arrhythmogenic cardiomyopathy or infiltrative or hypertrophic cardiomyopathy. In a patient with structurally normal heart, a VT may arise from outflow tract. Now, since outflow tract are superior structures, the activation is coming from high below. So this means it will be negative in the superior leads, that is AVR and AVL, and positive in the inferior leads, that is 2, 3 and AVF. Compared to a structurally normal heart, the underlying substrate in patients with structural heart disease may be ischemic or non-ischemic. In ischemic heart disease, a LBBB-like morphology VT mainly arises from the septum. Depending on the vessel involvement, this may arise from anteroapical or inferoapical septum in anterior wall MI or inferobasal septum in inferior wall MI. Another important thing to know is while AIVR of LAT or RCA may have a LBBB morphology, reperfusion of circumflex never has a LBBB-like configuration. A word about arrhythmogenic cardiomyopathy. So the changes in baseline ECG of arrhythmogenic cardiomyopathy, they reflect the underlying pathophysiology. So normally RV free wall is the last part to be depolarized. In presence of fibrofatty replacement of the RV, there will be delayed conduction in the terminal part of the QRS, and this may manifest as low frequency, low amplitude waves called as epsilon waves. Apart from this depolarization abnormality, there are repolarization abnormality. For example, T wave inversions in the anterior leads, flat T wave in the inferior leads, and the extent of T wave inversion usually correlates with the degree of RV enlargement. Also present on this ECG are interpolated VPCs or LBBB morphology and inferior axis. Patients with arrhythmogenic cardiomyopathy, they may present with VT morphologies of RV origin. These are associated with late transition in the precordial leads and may have inferior or superior axis, depending on whether the VT is arising from outflow tract or from the basal area. So these are my take-home messages. Approach patients with LBBB morphology tachycardia systematically. A typical LBBB aberrancy, keep the broad differentials that we discussed in mind. So SVT with LBBB aberrancy, MAHEM, or very rarely bundle branch reentry. SVT with LBBB aberrancy may be sinus or atrial tachycardia, maybe AVNRT, maybe orthotomic AVRT. Then compare with the baseline ECG, because sometimes you will get clues on the baseline ECG that is not present on the tachycardia ECG. And in presence of ventricular tachycardia, rule out underlying structural heart disease, because the goal is to treat the patient, not just the rhythm abnormality. Thank you.
Yeah, Mohan, over to you. Excellent talk.
Yeah, excellent talk. And I think once again, either LBB morphology, tachycardia or broad cumulus tachycardia is a very common point of discussion on the rounds in the clinics and again in the exam. And I think that all the ECGs with the explanation are extremely great pearls of wisdom. So what would a typical DNB student who's given a ECG of LBB morphology be expected to answer? I was just going back, trying to remember a talk I just took for DNB last week on broad QRS tachycardia. So at the DNB level, I just talked about the myths and realities. One, in an emergency situation is far more, any LBB morph. I'm just adding to whatever I've been told very beautifully. In an emergency situation or the emergency admissions, the LBB morphology or broad QRS tachycardia is more likely to be VT than SVT with aberrancy. This is just a few points just to add. Then, if you are given an ECG of, so if you are given a broad QRS tachycardia ECG exam or given a note to write in the written paper, which again I'm sure Dr. Rakesh Yadav would know whether it's coming in the paper or not. Then one is that it's technically more common to have VT. So you say that it's more likely to be VT, but could be SVT with aberrancy. Then very good points that were raised. The key to diagnosing a white QRS tachycardia is the AV association. Key is if you can make it out. So if a student says that I'm trying to look at the P wave and would like to do some maneuvers to bring out the P wave, that's an excellent answer, because if you can have a VA relationship brought out, then that clinches the diagnosis, as was discussed already. And then you say, of course, again, I think Yash always keeps pressing on the point that try to look at the, so if a student asks for the sinus rhythm ECG, again, that's a point that he understands how to go about it. Because ECG during sinus rhythm gives you as much, not as much information as the ECG during the tachycardia. So I think that it's what I would again tell the DNB students who are attending and those who are not attending is to keep this presentation, go over these ECGs that have been presented with their, points that were discussed, so that you know as a cardiologist, when you go into really being on your own, to go, how to go through your how the mind's computer should work when you see a broad QRS or a left bundle branch block tachycardia, and also for the exam, whether it's a short note or a full question on how to write. And if someone writes about these points, then you know that his understanding of broad QRS or a left bundle branch tachycardia is excellent.
Thanks, Mohan. I'll just give one point, a concluding point, that in one simple thing also is to look at the width of the QRS.
Yes, if it narrows.
More than 160, for example, in LBB, if it's more than 160, then by and large is a sick heart. And in a sick heart, if you got it, most likely you're dealing with ventricular tachycardia. And as Mohan says, when in doubt, treat as VT from a clinical perspective. I think good points. I think we'll move on to Akshay's first presentation, I think, ever. So we'll give him some leeway. Akshay, I'm sure he'll do a good job. Simple cases with simple take-home messages, Mohan.
Thank you.
respected teachers. Today I am going to present one case of intermittent tachycardia with LBBB. 52-year-old man, a smoker and hypertensive, presented to us with the complaints of dizziness, dyspnea on exertion, and slurring of speech. On examination, pulse was 40 beats per minute, BP was 190 by 110 mm of Hg, random blood sugar was 105, and he was maintaining saturation on room air. He was conscious oriented, but slurred speech was present, and other systems were no abnormalities were detected. This was the ECG when patient came to us in the casualty. ECG at a glance shows that there is a bigeminal rhythm with alternate QRS being the broad QRS. But if you look at it carefully, there is before a broad QRS, there is P wave, which is occurring, which is different from the sinus P wave, and it is negative in lead 2 and 3. So it is that ectopic origin is from the lower atrium near the interatrial septum, and so it is the ectopic atrial which is getting conducted through the LBB with LBB aberrancy. So this is the ectopic rhythm with LBB aberrancy. So this was the ECG when patient came to us in a cardiac ICU. By looking at the chest lead, one can see that it is looking like a sinus bradycardia, and one can say that it is only sinus bradycardia. But if you look at it carefully in the chest limb leads, there is a P wave which is occurring at the end of T wave, and it is also inverted in 2 and 3, but it is not getting conducted. So it is the ECG which is showing the premature atrial complex with the premature atrial complex which is getting blocked. So it is this was the ECG when the patient was given atropine. It is also showing that the post atropine there is no change in the ECG. So the likely block is the below AV node, that is infranodal block. So this was the ECG when the patient was started on isoprenaline infusion. You can see that there is an increase in the sinus node rhythm and disappearance of the premature complexes, and the sinus there is only disappearance of premature ectopic complexes. This was the ECG taken when the isoprenaline infusion was stopped, but there was some effect of isoprenaline. One can see that there is a slowing of the sinus heart rate and appearance of the ectopic P waves, which are all negative in 2 and 3, and they are getting conducted without any aberrancy. So there is normal conduction with the ectopic bit with normal conduction, but there are some P waves which are also getting blocked. So some ectopic P waves are getting conducted, and while some ectopic P waves are getting blocked. So because patient presented with slurring of speech with high BP, we did CT brain. It was suggestive of multiple subacute lacunar infarct in bilateral gangliocapsular regions and bilateral corona radiata. Routine biochemistry and the thyroid functions were normal. His echo was suggestive of hypertensive heart disease with concentric LVH with normal EF. We did the Holter trace for him. The first Holter trace, you can see that there is ectopic P wave which is occurring at the end of T wave, and it is not getting conducted. The second trace, there is a ectopic P wave is getting conducted, and while in the third trace, the ectopic P wave which is occurring at the end of T wave is not getting conducted. These traces can be labeled as a 2S21 AV block. So it can, the patient may undergo unnecessary pacemaker insertion. So one should look at this very carefully, the tracings of the Holter trace. So we should not misdiagnose the patient. So the premature atrial complexes are mostly they originate from it is of idiopathic cause. They usually originate from upper pulmonary veins or right atrial appendage or coronary sinus ostium. They are also associated with structural heart disease like valvular heart disease, congenital heart diseases like atrial septal defects, hypertrophic cardiomyopathy. They are also common in patients with elderly patients with hypertension, chronic lung disease, and thyrotoxicosis. They beta agonist, digoxin, tricyclic antidepressant. So these are some drugs which can also increase the atrial premature complexes. The incidence of premature atrial complexes is high in patients with myocardial infarction, congestive heart failure, diabetes mellitus, patients with obstructive sleep apnea. Pregnancy is also important condition where we can get lot of atrial tachycardias or premature atrial complexes. Anxiety, alcohol, tobacco are some of the other causes. The atrial premature complexes can be unifocal when the P wave is of same morphology and they are originating from the same site, while they may be multifocal when the P wave morphology is different. Multifocal PACs are more likely to propensate into atrial fibrillation. When the PR interval is short, that is less than 120 milliseconds, the origin is likely to the lower right atrium near the AV node. And if the P wave is negative in lead 2 and 3, the origin of ectopic atrial complex is lower atrial. While if the P wave is negative in the AVL and is positive in V1, then the origin of the ectopic atrial complex is left atrium. So most of the time these premature atrial complexes are benign in nature and nothing is to be done, nothing is required to be done. Only reassurance of the patient is important. When patient is symptomatic, one can try antiarrhythmic drugs like flecainide or sotalol, and the RF radio frequency ablation are very rarely required when the patient is quite symptomatic and when the patient is treated with medication and underlying triggers have been treated. Then also if patient is symptomatic, then rarely radio frequency ablation is required. Treatment of underlying trigger like COPD, this is also important when there is a cause for the PACs. Drugs which can be used in without structural heart disease are the flecainide or propafenone, and the sotalol and amiodarone can be used when patient with or without any structural heart disease. So this was the ECG of our patient when we started him on the tablet flecainide 50 mg twice a day. So you can see that there is a disappearance of the ectopic P waves, and there is patient is in the sinus rhythm. So these are the some references where Amit Tora sir and Yash Lokhandwala sir have also done the radio frequency ablation of the premature atrial complexes. These are the some other references where they have done the radio frequency ablation of the premature atrial complexes. So the take-home message being the blocked premature atrial complexes are the common causes of pseudobradycardia, and they can misdiagnose as sinus node dysfunction or 2S2 and AV block. The patient may undergo unnecessary pacemaker implantation because of, so one should avoid it by careful ECG examination. And when patient is symptomatic and there is no reversible cause, definitive treatment is possible. Thank you.
So Mohan, you can give the comment starting with the question in the chat box. And the question is that how to differentiate sinus tachycardia and ectopic atrial tachycardia.
Yeah, I saw that. Thank you, Yash. I think it was again one wonderful presentation, considering that we are addressing, particularly considering that we are addressing DNB students. And one of the references could be the case, absolutely marvelous case that was published by John Roshan and his team from Vellore in Circulation Case Reports, similar to the one you presented, but with a little bit of new nonsense and, you know, why jumping into a pacemaker is not the right idea. Apart from that, the sinus tachycardia versus atrial tachycardia, I think, again, is a very, to look at the P wave morphology very carefully. It's sometimes difficult in a, you know, Holter, you see these sinus tachycardias, which go up to 170, 180 in young people. And you don't know whether this is some form of an inappropriate sinus tachycardia or atrial tachycardia. So that decision making is critical to clinical management. So I think that the only difference would be the looking at the P wave morphology carefully. If you have an obvious difference in P wave morphology during the tachycardia as compared to the normal sinus rhythm, then of course it is an atrial tachycardia. Then it is onset and offset. But again, some of the crystal tachycardia can look like sinus tachycardia in onset and offset. But most of the atrial tachycardia would have aberrant onset and aberrant decrease. So these are some points which can help you differentiate between atrial tachycardia and sinus tachycardia. Coming back to the bundle branch block seen during the whatever episode that the patient was having. Again, what led to the right diagnosis was the careful looking at the P-QRS relationship, and of course, looking at the P wave morphology. So I guess most of the points have been covered, and there are any more questions, I will be. When there's some more questions in the chat box.
I think one point that Akshay probably mentioned, and I didn't hear or you overlooked, is that why do some of the PACs conduct and why do some of them block? You should, as a student, try to question this. And if you notice in this patient, the two factors, how early the PAC comes, and that is one. And second, what is the preceding preceding cycle length? These are the two questions. So if a PAC comes, the ones that got blocked, if you notice, they all came on the T wave. And the ones that got conducted came just after the end of the T wave. So that's one of the reasons. And the second is that the preceding RR interval, if the longer the preceding RR interval, the more will be the refractory period of the conduction system. So if the PAC is preceded by a longer RR interval, it probably will more likely get blocked than if it's preceded by a shorter RR interval. So these are the questions you should ask yourself. The other thing is that often on a Holter, this will be diagnosed as a ventricular bigeminy. And many times non-sustained atrial tachycardias are misdiagnosed. If they have LBBB on a Holter, they are misdiagnosed as ventricular tachycardia. And inappropriate treatment, including implantation of defibrillators, has taken place in such patients. So be careful. Whenever dealing with the arrhythmia, if you look at the 12 lead if possible, otherwise at least in the Holter, try to dissect out. This same patient at other times has atrial tachycardia, which is narrow QRS. Then the one with wide QRS usually would have been atrial tachycardia. And this conduction system can be diagnosed only when it occurs at a normal rates, not with the premature complexes. So I think with that, we'll move to the last case of
regarding the Holter. I was coming to that. If you have an issue before jumping to treatment, and you cannot capture these on a resting 12 lead, then you can ask now for a 12 lead ambulatory monitoring. In that, please differentiate. There are two types of 12 lead ambulatory monitoring. One is true or near true 12 lead ambulatory. The other, the 12 lead, most of the leads are derived 12 leads. So the Holter is a derived 12 lead, then you again cannot make your decision. It has to be a true, ask for a true 12 lead Holter, and then look at the P wave and the PQRS relationship. So that's just a practical point.
It's a crucial point. I think that's a very good point. And I'm sure the students, all of you are attending, these pearls that all your faculty are giving you and the presenters are, I think these are going to stand you in good stead. So Rakesh, I would request you to, as Mohan has repeatedly said, make these presentations available to all the students who are attending today, and even those who are not attending today, Rakesh.
And also leak some of the questions that you are aware that are coming in.
So tomorrow it will be uploaded in the IHRS website.
Okay, great. So that's good. The Indian Heart Rhythm Society website has all these. So please, the students, these are excellent teaching resources. Please visit the website. I think it is www.ihrs.org or something, isn't it, Rakesh? Anyway, it's there in the link. is there in the link. So let's go to the last. Dr.
Or
Soni
if you have a Google search, IHRS and right IHRS India, whatever it takes you to the right link.
Okay. So Dr. Soni is going to present again a simple case, but simple. Don't get overawed about pacemaker. We just wanted to give a simple insight into pacemaker ECG in this case. Yeah, Dr. Soni, share your screen and
Yes,
start.
sir. Yes, sir. Good afternoon, respected teachers, my seniors, colleagues, friends, and juniors. Today, I am presenting an interesting case with LBBB morphology tachycardia after a pacemaker implantation. There was a 20-year-old woman with known case of Duchenne muscular dystrophy, she was in follow-up in neuro OPD, presented with history of multiple episodes of syncope. She came to EMS and she was admitted basically in the neurology department as she was in follow-up there. The ECG was done, which shows narrow, complete heart block with narrow escape rhythm. And for this ECG, cardiology reference was done and patient was shifted to the cardiology department. Dual chamber pacemaker implantation was done, and day after the implantation, the first day post-op ECG is just attached in the screen right now. The post-ventricular atrial refractory period was set to 330 milliseconds and the upper tracking rate is 120 per minute. What we are seeing in this ECG, that there is a normal sinus P wave followed by ventricular pacing, and this ECG is a high pacing rate with intermittent pauses. There is a retrograde conduction is seen, and again there is a ventricular pausing, and followed by the few beats there is a pause, intermittent pause, and there is again a sinus P wave. The differential diagnosis in our mind is was the pacemaker malfunction, retrograde conduction with P wave tracking in upper rate behavior, sinus tachycardia with upper rate behavior, and atrial tachycardia with upper rate behavior. Now I am just showing an elaborating brief in the ECG. There is first is the sinus P wave, which is just conducted, and there is a ventricular pacing. Followed by there is a retrograde conduction, negative P wave, which are pointed. These all are pointed P wave, and different from the sinus P wave morphology. There is a pause. There is again a sinus P wave.
Dr. Soni, your R notifications have moved. So tell everyone to ignore that they are moved. They are not aligned with the P wave. Anyway, carry on.
This is the ladder diagram, which is showing that there is a pause, there is the atrial refractory pause. The retrograde P wave was not conducted, which fall in the post-ventricular atrial refractory period, and this is the not conducted retrograde P wave.
No, Dr. Soni, it's not a question of not conducted. The retrograde P wave means it is there. It goes to the atrium, but it is not followed because it has reached the upper rate.
Yes, sir.
Because the pacemaker has reached the upper rate of 120.
Yes.
So this is not a pacemaker malfunction. This is a way a pacemaker protects against going to very rapid rates.
Yes, sir.
But can I add one thing? It is basically a Venki back phenomena which is done by pacemaker. Carry on.
When you have a group beatings, with your baseline ECG itself showing a lot of group beatings. So whenever you have group beatings in a tachycardia zone, always think in terms of a Venki backing somewhere. So if it is in a sinus rhythm, it can be a Venki backing in the AV node. And if it is like a pacing patient, think of a condition where you can expect Venki backing somewhere, and you can come to the diagnosis based on that.
There are few studies which have already shown that The site of anterograde conduction block was located at the infrahacian level in almost all patients with retrograde conduction. There is also one study which shows that paradoxical phenomenon of retrograde VA conduction in complete AV block has long been recognized in post-implantation patient. We have increased the post-ventricular atrial refractory period in that patient, and we increased to 360. Then there is normal atrial sensing and there is ventricular pacing, and then there is again the ventricular pacing. There is retrograde conduction, but which is fall in the post-ventricular atrial refractory period, and that was not conducted. The key points on pacemaker tachycardia that it occurs in the dual chamber tracking mode in patient with intact VA conduction. PVC are the most common trigger of the pacemaker tachycardia, but any condition which causes atrioventricular dissociation, either a PAC or atrial oversensing or undersensing, may produce this pacemaker mediated tachycardia. Pacemaker mediated tachycardia often occurs at the upper rate of the device, and it can be terminated by placing a magnet over the device, or we can easily terminate it by increasing the post-ventricular atrial refractory period. Thank you, sir.
That was a good demonstration of tachycardia in a patient who had a pacing. I think a lot of important clues you can derive out of the baseline ECGs. So whenever you see these group beatings, think of Venki packing somewhere. And more than that, when you do the analysis, your markers in the pacemaker channel will help you in coming to the diagnosis. And you should know what are the safety algorithms does the pacemaker have to prevent this pacemaker mediated tachycardias, these PVARP extensions. Now, each company have their own algorithm to treat or prevent the occurrence of pacemaker mediated tachycardia. These are very important things while doing programming and to avoid the recurrence of such symptoms.
I think this is a wonderful presentation, and it just should open the mind of the students to look at pacemaker ECGs and analyzing the pacemaker ECG, because you might again be given a case, or you might have to be called upon to address in a clinical situation a patient with a pacemaker ECG. The best way to learn is go through the, like Shanmugam said, they are becoming more and more complicated with the software that the pacemaker has. But there's nothing to worry when you are given suddenly a pacemaker patient, patient with a pacemaker ECG. If you know the basic, keep looking at these ECGs in day-to-day practice as they are implanted and they are troubleshooted by your team. Then by the time you go to the exam, because it's very common to see the patient going I'm so sorry. The student going totally nervous when he's given a patient with a pacemaker paced ECG, he comes out with all kinds of answers, which is understandable. But if you're cool about it and look at it, like Shanmugam said, and see the Venki backing, and then after a Venki backing, only the laws, then you know that it's not pacemaker malfunction, but proper functioning of the pacemaker. So don't get, and again, these are the opportunities where you get to understand and see the discussions around a pacemaker ECG. So if you attend or go through some of these ECGs whenever you get a chance, then in real life when you're on your own or in the exam, you're more you don't get start sweating when you see a patient or are given an ECG, and of course Rakesh would know whether the theory question about analyzing a pacemaker ECG is coming. But both these things somehow most students are scared to answer, which is not the way. Maybe Ashish would have a full session on pacemaker and pacemaker ECGs with again Shanmugam as the chair. He knows the different types of new and current way the pacemakers are going, because there is a question in the chat box about where the pacemaker lead is placed. This is again relevant in today's world. It's not always the RV apex or a screw-in lead in the RV OT. It can be wherever, you know, wherever Shanmugam is teaching us to do, we are trying to do. But where it lands up is another question. So a very nice presentation, excellent.
So to add a couple of points in the chat box, people have probably still not understood this concept of Venke barking. Now, see, don't get scared when you see a pacemaker. The first reaction of the students is to get overawed, to, you know, and then, you know, in the exam to totally get flustered. Just approach it systematically. Now, here we have told, or whoever has implanted the pacemaker has told the pacemaker, do not exceed a pacing rate of 120. So the pacemaker is smart enough, if it every retrograde P wave is sensed and keeps on pacing, it will cross 120. So the pacemaker uses, in this case, different pacemakers may use different types of things. Previously, the pacemaker would suddenly go into 2:1. So the rate would suddenly drop from 120 to 60. Nowadays, most pacemakers, Venke bark to maintain it close to 120. So this is a normal pacemaker function. The pacemaker chooses to ignore one P wave to keep the upper rate around 120. So it's a normal pacemaker function. And here, yes, the pacing side, as you rightly saw, was the QRS axis was vertical. So you are and there was an initial Q wave in lead 1. So you're probably pacing higher up, definitely, and near the interventricular septum, not the free wall of the right ventricle. Now, it's important to look at these things because in the initial 24 hours or 48 hours after a pacemaker, then the evening of the pacemaker and the next day, look at the ECG, see if the axis has changed, because that is the first clue that the pacemaker lead has moved. And also learn to check the parameters of the pacemaker. And the temporary pacemaker also, I say, when it's implanted, very relevant. You know, whenever you're doing, take a 12-lead ECG, at least 12 hourly, to know whether the temporary pacemaker is moving in the heart or not. And one of the only early signs could be, of course, loss of capture is one, but you may just see a change in the axis. And also on every day on the rounds, look at the battery, look at the threshold of capture. These are things which, you know, people are, I don't think many students are doing, but please make it a routine practice to do this. So I think those are some of the points. I think there is one more comment or question on the chat box. So Dr. Sanjeev Kathuria has written, you can go through it. He has given further explanations about the Venke bark with the pacemaker. So all in all, Rakesh, we had a good day. I am sure useful presentations. Can you make the closing comment when we can close the session?
I think it's a wonderful and this DNB teaching program. Believe me, I am a DNB and DM both examiner. So this pacemaker ECG, usually we keep only 4 or 5 ECGs. Hysteresis ECGs, upper rate behavior, capture failure or sensing failure. So today, I think Dr. Yash and your team has presented wonderful cases and they are pertaining to DM and DNB exit examination. Thank you.
Thank you, Char. Thank you, Mohan. Thank you, Shanmuga, for being there and sharing your pearls, and everybody else. And we can see today, there were many questions on the chat box also. So I think these topics were therefore, people felt in their day-to-day work, and these would be important. So the purpose seems to have been served, and we can then, Rakesh, close the session. And thank you very much, everyone.
Yeah, thanks, Yash, and huge congratulations and a round of applause to your young team. I mean, I'm really so happy to see this. And of course, always having you, Rakesh, Shanmugam, and all. A wonderful, excellent Sunday. Excellent start to a Sunday. Enjoy the rest of the weekend, and we'll get back to some more teaching. Thanks a lot. Thanks for the opportunity, Ashish, and putting it all together too. So thanks.
Thank you, sir. Thanks for the opportunity.